Away here with OrthoBiologics 101, and a little bit the goal here is just to get everyone introduced to this. And I know not everyone here is within this world of sports, but it's something that you're going to start hearing from people in kind of all walks of life and in all different orthopedic clinics. And there's an inherent bias for me in sports because that's what I do. But again, this has become very generalizable, and you're going to start hearing this from family and friends if you haven't already from patients. Disclosures are non-relevant here. And so just a simple Google snapshot here. If you search OrthoBiologics on Google, in half a second it returns 192,000 results. Stem cells returns 426 million results. And now this is out of context of anything, but it just gives you an idea of kind of where we are with these two buzzwords in our topics in orthopedics. And so the question of biologics in orthopedic surgery and elsewhere for that matter has become whether these, quote, stem cells are really the holy grail of what we're doing in our treatment algorithms going forward. And by consequence, you start to see this exponential rise in biologic companies and orthobiologic institutes across the country. And the question is, what do I make of all this? And how, where, when, why do I incorporate this in my treatment of orthopedic patients? So the list goes on here. I don't even know where I have this stop. But this is an example here of a de-identified patient's bill that one of my future partners sent over to us to look. This is a patient who had end-stage clear bone-on-bone subtalar arthritis, who came to this particular surgeon after going to one of these stem cell treatment clinics out in our community, who had paid $10,000, I don't know if you can see it, but $10,000 worth of, quote, stem cell injections prior to coming to him as one of the treating definitive surgeons. And he did her subtalar fusion, and she had remarkable relief, but not surprisingly, wasn't doing well with these paid injections over a couple of months of time and lost some time and money certainly with this. And so it's something to be aware of. And so with this talk, I'm going to attempt to provide an understanding for everyone on the basics of orthobiologics, what they are not, how we can use them, and how we should use them. And I'll talk some into the terminology and semantics of the subject and examples of what's available for use, the evidence surrounding it, and future directions. So I think there's a responsibility we have as orthopedic practitioners to our patients in this respect. So why is this important? I think we need to be aware of recent literature and knowing the indications that guide clinical decision-making and managing patient expectations. I think we need to appreciate federal regulations, billing, and coding policies for these treatments, and to be able to discuss the risks, benefits, and alternatives, as well as expected outcomes. A fundamental challenge at this time is the fact that we have low levels of, thank you for that, is that we have wide variability in some of these materials and formulations, and we lack level 1 data from controlled clinical studies due to the heterogeneity between patients and pathology treated. And so now more than ever, there's a high patient or originated demand for biologic treatments of orthopedic conditions. And this is spawned in part from direct to consumer marketing of largely unproven biologic treatments like PRP and cell-based therapies, but also from the prevalence and seriousness of musculoskeletal conditions and how they affect our population. And then there's a lack of satisfactory conventional treatment options available for such things as osteoarthritis or joint pains and aches. And so patients are eager and willing now more than ever to try anything to get back to activities, and treating physicians want to be seen as offering the latest and greatest treatments out there. And if he or she is not offering it, it's a good chance that somebody down the road is. And so our duty is to combat misinformation that may erode the public trust and the responsible investment needed to bring patients legitimate biologic therapies. And so the responsibility in improving and accelerating clinical evaluation, use, and optimization of these biologic therapies for musculoskeletal diseases falls on our leadership, such as the PAOS or the AAOS or the AOSSM, but trickles down to us as practitioners who have the capacity to treat patients with these biologic therapies at will. You know, on an individual level, there's nobody monitoring our clinics as we're taking care of these patients with these different options. And so to address these concerns, earlier last year, the AAOS convened through leaders from clinical medicine, research, and within the government at Stanford, and kind of developed a think tank symposium on optimizing clinical use of biologics in orthopedic surgery. Participants included academic and private practitioners, basic and clinical scientists from academia, patients, representatives from the AOS, the National Institute of Health, AOSSM, AANA, the International Cartilage Restoration Society, and Joint Preservation Society, and keynote speakers from the National Institutes of Standards and Technology, as well as the Stanford Center for Innovative Study Design and the FDA. And so it's a mouthful of who was here at this, but what they really tried to do was get some of the brightest minds in this topic out there to try and sit down, spend 48 hours discussing the risks, the issues that we have at hand and how we can combat these. And so the goals were to, number one, establish a clear collective impact agenda for improving the clinical evaluation, use, and optimization of biologics and orthopedics. Number two, to develop a guidance document on clinically meaningful endpoints and outcome metrics to accelerate the evaluation of biologics for common orthopedic conditions. And so I'll highlight in context some of the recommendations as we go through things here today. From a product overview standpoint, I'm going to try and highlight platelet-rich plasma, bone marrow aspirate concentrate, adipose-derived stromal vascular fraction, amniotic membrane allograft, and then umbilical cord-derived products. And maybe just by a show of hands for me to provide me with some understanding, how many of you all out there are getting patients who you're taking care of with these types of therapies? Are you using these in your clinics right now? So some of you guys, a good amount of you guys out there. And then again, I think as we go on, regardless of what type of practice you guys are working in, you're really going to see this exponentially rise in the coming years in particular. So beginning with platelet-rich plasma, or PRP, which we'll spend a little bit of disproportionate time on because this, compared to the other treatment options, reflects our disproportionately greater knowledge of it as compared to some of the other things I'll talk about. So the process for PRP harvest and preparation first includes intravenous access to draw approximately 60 cc's or so from a peripheral vein in the arm. The blood is then centrifuged per the recommendations of whichever manufacturer is being used. And this creates an autologous concentration of human platelets in a small volume of plasma on the buffy coat, as well as separate layers of RBCs and platelet-poor plasma. And so here's the centrifuge. The red blood cells and platelet-poor plasma are then discarded to isolate the platelet-concentrated layer, and the final product is then injected back into the patient, either blindly or with localization, with ultrasound, under direct visualization at the time of surgery, and with or without activation via the addition of either calcium chloride or thrombin. And these are all manufacturer-based and proprietary-based ways of doing this. And to some degree will cause these platelets to then degranulate and release growth factors and differentiation factors, which is really the mainstay of what PRP is doing. The idea behind PRP, again, is its ability to deliver numerous growth factors and cytokines in physiologically relevant proportions. So the basic science data demonstrates positive effects, but there is mixed clinical efficacy when evaluating things like healing bone in the fracture setting, soft tissue type injuries around the joints, and treatment of degenerative joint conditions like knee and shoulder arthritis in particular. PRP is an autologous option, is harvested from venous access because being harvested from venous access makes it easily available, but it does require, by definition, 3 to 5 times the baseline counts from serum. And interestingly, PRP composition is known to vary widely when blood from the same individual is obtained at even different times of the day, or based on which manufacturer they're using. And furthermore, these growth factors and cytokine concentrations will vary by donor age, health status, and sex. And so what this does is it tells us, in effect, we don't always know exactly what we're putting in the body with these. And we think we know, and we like to think that we have this standardized as possible. And in a lot of ways, there's some of the proprietary measures that will tell us what we're injecting. But if you inject one patient one day versus that same patient later that day or the following day, you're not necessarily going to get that same yield just from that patient's autologous blood. Again, these platelets then lead to a 3 to 5 time increase in growth factor concentrations to augment the body's natural healing. And so it's more so through cell growth, differentiation, cytokine secretion, paracrine cell recruitment effects, and blood vessel growth that we're seeing the effects of this platelet-rich plasma. And so it's not that you're taking this from the body, getting stem cells and injecting stem cells. That would be an inappropriate way for us to think about it or to discuss it with our patients. It's really more than anything probably the paracrine effect and cytokine effect of platelet-rich plasma that's doing what it's doing in different parts of the body as we'll go through. And here, just again, a list of some of those different cytokine growth factors and the basic science behind them and why it makes sense that this would be beneficial in some of the different ways that we're using it. So it's really important to understand that not all PRP is the same. The variables really do matter, including in particular the platelet count, and then specifically, as you'll see, the white blood cell inclusion and formulation. And so currently there are more than 16 commercial PRP systems available on the market, and there's quite a bit of variation therein that exists with PRP collection and preparation, depending on which commercial system is being used. Each commercial system has a different platelet capture efficacy that results in a different whole blood volume and its requirements to achieve the necessary final platelet concentration to be deemed PRP. The commercial systems also may differ in their isolation methods. Some are 1- or 2-step centrifugations, the speed of that resultant centrifugation, and the type of collection tube and system in operation. So you need to know what system you're using to really understand what you're getting and what it can or should be used for. Leukocyte concentration, again, as it relates to growth factors and interleukins recruited within the location of use, is important. And so leukocyte-rich leads to an increased inflammatory milieu, which you need to think about because if you're injecting this into something of an inflammatory type condition, you're not going to want to increase the amount of inflammation you're putting into there, like in knee arthritis. Whereas a leukocyte-poor type formulation will encourage anti-inflammatory mediators. Leukocyte-rich PRP thus may have deleterious effects on chondrocytes, cell death of synoviocytes, and so if you're putting this into an arthritic knee or some other inflammatory condition, you're actually doing a disservice to the patient, even though you're giving them PRP. So you need to identify, again, the optimum formulation depending on what you want to try and do. And at its base, you're thinking about, really, I like to think the white cells as being the key kind of decision algorithm part of that tree, whether or not you want to be inducing inflammation or not. And so in an arthritic condition, we're thinking, again, this is an inflammatory type, end-stage, painful condition where you want to use leukocyte-poor PRP, and we'll show some data behind that as well. For tendinosis, like lateral epicondylitis and patellar tendinopathy, things that are overuse type symptoms where you're getting poor blood supply and you're getting these death of cells, you're going to try and actually increase the amount of inflammation there. And as we know, a lot of the treatment that you're doing for these overuse tendinitis type things is to try and stimulate new blood formation. And PRP leukocyte-rich is going to help you to do that. This compared to Achilles tendinopathy, which we'll show, which is kind of a little bit the odd brother on that one, where it follows the same kind of pathophysiology and etiology, except we haven't seen the data bear out for that quite like we have for lateral epicondylitis or patellar tendinitis, and we're not exactly sure why. And then muscle as well, platelet-poor plasma might actually be more appropriate for there. And so that PPP that you might be discarding in other circumstances has been shown to be beneficial for intramuscular type injuries to the hamstrings or the quads. And so there's a difference also in the MRI findings or histologic findings and clinical benefits of when you're using these. And so some of these might not be doing exactly what you're expecting to change from an imaging standpoint, but the clinical benefits are getting better. And so, again, there's different metrics with how we can and should measure these because you can't expect that an arthritic knee is going to all of a sudden get an MRI 6 months later and have a regrowth of cartilage from a PRP injection, because we're really not trying to do that with a PRP injection. We're just kind of treating that local milieu of inflammatory mediators. And so what does the literature suggest about the use of PRP and its evidence? I'm just going to highlight some of the larger scale studies that are often cited. And again, these are a little bit more biased towards sports type studies because, again, that's where my research and interests lie. But again, reflects a little bit of where this research has been done. But we're seeing it move into some of the other fields of joint replacement and trauma as well, for instance. But this study by Pierbooms et al. In AJSM 2010 compared leukocyte-rich PRP with corticosteroid injection for recalcitrant lateral epicondylitis. And again, leukocyte-rich PRP in this lateral epicondylitis pathology at a year found significantly improved DASH scores and successful response compared to steroid. And we've seen this kind of repeated with other studies, again, for chronic lateral epicondylitis in terms of pain scores and residual elbow tenderness from this 2014 AJSM study by Mishra et al. Dragou et al. In 2014 reported significant improvements in patellar tendinopathy, a kind of analogous condition in the knee, with ultrasound-guided leukocyte-rich, again, PRP at 12 weeks, but not sustained at 26 weeks in comparison with ultrasound-guided dry needling alone. And so we're wondering if in this condition, is this efficacy maintained at the longer-term follow-up? By comparison, again, Achilles tendinopathy seems to have no improvements in tendon structure, neovascularization, or clinical outcomes with leukocyte-rich PRP use in comparison with placebo. And then here, looking just at the systematic review on PRP for knee-OA, kind of one of the earlier ones that showed leukocyte-poor formulation as having the potential for symptomatic relief up to 12 months, particularly for those with lower grades of OA. And I think that theme holds true in a lot of these treatments as well, of where we've seen a lot of it better in these early to moderate type pathologies, and as opposed to those end-stage bone-on-bone varus knees where you're dealing with mechanical malalignment, lack of cartilage in its entirety, and you're trying to decrease inflammation, but without being able to really change the mechanics of that joint that's causing the pain in part. It's hard to expect that your injection treatment's going to really necessarily be the end-all be-all for some people. And again, another study here just showing support for leukocyte-poor PRP for knee-OA in comparison to, in this study, both hyaluronic acid and placebo treatments. And then in terms of surgical augmentation, which is another area of interest outside of the clinics when we're injecting these for different concurrent treatments in the operating room, PRP here didn't seem to universally improve re-tear rates or affect clinical outcome scores for arthroscopic rotator cuff repair, even though we really want it to, and there's been dozens of studies that have been looking at this over the last decade. But these factors did trend toward improvement if you really focus down the subgroups of solid PRP matrix placed at the bone-tendon interface in small or medium-sized tears. And I think, again, this goes along analogously with those earlier to early moderate degenerative conditions. Maybe there is a role for these types of treatment for PRP in these small or medium-sized tears after you bring them down, where it's less a mechanical concern of these huge, large, or massive tears. And really, you're just trying to tack them down and encourage the biology to improve. PRP and ACL surgery may benefit graft maturation and tunnel healing, but has not shown the same benefit on functional outcomes from the currently available literature. So it's still being evaluated. And finally here, leukocyte-rich PRP when compared with rehab alone had significantly shorter return to play for athletes when used in grade 2 hamstring muscle injury. So again, just a spattering of some of the studies that are frequently referenced in these types of talks as we try and look at where PRP has been beneficial, and we're continuing to try and evolve our understanding and indications for its use. I'll switch gears a little bit to bone marrow aspirate concentrate and adipose-derived mesenchymal signaling cells here. But it brings us into first, I think the most important part of the discussion is what is and what is not a stem cell. And the NIH characterizes stem cells based on them having 3 general properties. And this is, number 1, the capability of dividing and renewing themselves for long periods, being specialized, and then number 3, having the ability to give rise to specialized cell types. And all 3 of these properties must be present to actually categorize a cell as a stem cell. And so stem cells have unique characteristics that are not met by minimally manipulated cell-based therapies being widely marketed in the United States. And I think we see this and hear this on the radio and on TV, where these stem cell clinics, or even some of us and our colleagues in clinics, are suggesting these stem cell therapies and stem cell treatments that they can inject, when the truth is a lot of what we're injecting is either minimally stem cells or not stem cells at all, and we have to be careful about that. And so, FDA restrictions on expanding or manipulating MSCs, such as culture expansion or enzymatic digestion, limits one's ability to optimize cell concentration and characteristics prior to implantation. And so products registered under Section 351 require an investigational new drug exemption and biologics license application on file with the FDA. And so again, what this is saying is what we're doing are in these minimally manipulated homologous use type injections at the time of surgery in the clinics really doesn't allow us to do exactly what we can do in the labs or what some of our colleagues overseas are doing as far as enzymatic degradation and changing these different harvested treatments to actually get down to what are true stem cells. And so what we're injecting a lot of time is not that. The International Society for Cellular Therapy defines true stem cells in their words based on CD expression or lack thereof, differentiation ability, and colony-forming unit ability in culture. And so again, it's not just pulling some cells out, suggesting that they're stem cells, and then that's it. There's really a rigid and strict definition for it that comes from the basic science world as they're studying these types of things in the laboratory. Again, therefore, it's a leap to characterize things like BMAC or adipose-derived mesenchymal signaling cells or stem cells as a complete population of stem cells. Really, these tissues contain stem and progenitor cells, but these are actually the least abundant cell types in these preparations. So depending on the tissue of origin, only 1 in 1,000 for fat or 1 in 1 million for bone marrow cells harvested from healthy tissues are stem or progenitor cells that are capable of differentiating into one or more connective tissues, such as bone, cartilage, and fat. And so for many indications, laboratory manipulation, again, and culture expansion are needed to isolate and adequately enrich these cell populations, and we're not allowed to do that yet in the United States in our treatment algorithm. Prime examples of true pluripotent stem cells, to give context, are your embryonic stem cells derived from early embryos or blastocysts with the ability to generate progeny that can differentiate into any cell type. That's your true stem cell. Use of embryonic stem cells, though, is limited at this point from ethical controversies and safety concerns in the government, so we're not actually able to inject these. Culture expanded cells would have a more expansive property than what we're using, but currently, again, requires that FDA-approved 351 clause in order to use in clinical trial use only. And so what we're using without regulation in our day-to-day clinics does not meet this culture expanded definition either. But we can use these in study when it's deemed okay to use for the study purposes. And so virtually, again, all of our current cell therapies offered in the United States for musculoskeletal conditions in our clinics involve the transplantation of adult cells obtained through harvest and minimal manipulation, that's that key word, of native tissues, again, coming from the blood, the bone marrow, the fat, as we'll talk about a little bit. And so the terminology here is important in that we should distinguish these uncharacterized, minimally manipulated cell preparations and tissue-derived culture-expanded cell populations as cell-based therapy rather than calling it stem cell therapy as it's widely known, just based on our current abilities. It's somewhat of a misnomer. And so if I leave you all with anything from this, it's just that understanding that, again, we need to be careful about how we're marketing these things and how we're proposing it to patients and what we're calling it. Because we have that responsibility to understand what we're putting into their bodies, and they should have the right to know what is or isn't going in there and in what concentrations. So it's thought, for instance, that these cells overall have a benefit in pain relief and things like osteoarthritis, more due to modulation of inflammatory mediators present in the joint rather than being stem cells that are becoming cartilage cells and finding their way back into these focal chondral defects or degenerative conditions. And so it's modulating nociceptive mediators like bradykinin receptors, tachykinin, NGF, matrix metalloproteinases, chemokines, reactive oxygen species, all those things in our biology textbooks along that inflammatory cascade of things like arthritis or other degenerative conditions. These may have a significant paracrine effect as well in stimulating our body's own pluripotent cells to come to action at the site of injection. And so I just recently heard a talk with Ashish Bedi, who's out in Michigan, who had referenced a study that they had recently done in rats where they actually provided them with a chemotherapy type drug to try and reduce the body's immune response, to then injecting these types of cells to try and get a dumbed down version of the immune response, which would allow as much paracrine effect as possible, and saw some of these paracrine effects actually as being the most beneficial. And so again, it comes to the discussion of what are these cells actually doing in the joints and what aren't they doing. And so here again, just a slide that I'm not going to go through because I never understood it when I learned it in high school. But this entire cascade is being moderated. And so here I'll just show you, if those of you who haven't seen this harvested, the process by which bone marrow aspirate concentration, or BMAC, is harvested from the iliac crest. And that's the site that the literature would suggest is the gold standard location for cell harvest. And what you're seeing is this Jamshidi needle is being malleted into the bone here, into the cancellous region of the bone, pulling back cells, turning as you're doing so, and then again going slowly. For those of you who are actually doing this, there's data to suggest that pressure derived from huge pulls and giant vacuum type suctions is actually killing a lot of these cells. And so the the way you want to do it is nice and slow, turning, pulling back blood, getting this good harvest from wherever you're doing it. This is then spun down by whichever proprietary means are available for you. And again, all of these have varying levels of white and red blood cells and hematopoietic progenitor cells. And some of them will spit those numbers out for you. But again, the context there is important. One of the concerns with bone marrow aspirate concentrate is the reduction in differentiation potential of the harvested MSCs, mesenchymal stem or signaling cells with age. As compared to PRP, there's fewer high-level studies evaluating the utility of BMAC. It's been looked at in some capacity for injections in knee arthritis, patellar tendinopathy, and lateral epicondylitis. Again, we're seeing themes of what pathologies are out there and being tested and studied, and the reason being is that their incidence is astronomical. And because of that, the ability to try and combat these in either non-surgical or augmentation of surgical type pathologies is really what's important. We're also seeing them tested as an adjuvant, an adjuvant for rotator cuff repair, focal chondral defect repairs, or meniscal injury as well. So again, just to highlight a few of the recent studies out there, this one from Pascal Guarido in 2012, they looked at just a small case series of patients, and there's only 8 in total, but published in a high-level journal nonetheless, just because of the infancy of this technology at that time, who had sustained benefit at 5 years of structural and symptom relief after BMAC injection for chronic patellar tendinopathy. Hernigu et al. In 2014 showed a 100% healing rate of augmented rotator cuff repair in their BMAC patients, 45 of them at 6 months compared to 67% in their control group. And a significant difference was maintained even at 10 years out, and 87% intact tendons compared to 44% of the control group. Gobi et al. In 2015 showed no difference, however, in their use of BMAC for patellofemoral chondral lesions in comparison with MACI, a cartilage-type treatment option, at 3 years after treatment. And so again, here we're just seeing that our understanding of this is infant. And so as years go by, and particularly in this point, as that exponential rise is kind of hitting its peak, we're going to see a lot more data out there for it and better understanding of it, hopefully. Next, Adipose as another source being used for harvest of mesenchymal signaling cells and endothelial precursor cells in its stromal vascular fraction. That's its important part, like platelet-rich plasma is to that whole blood harvest. Adipose is considered a more concentrated source of MSCs than BMAC is, as I alluded to before. And the potential stem cells or progenitor cells are thought to be more so the parasites embedded in the basement membranes of capillaries. But enzymatic digestion is often needed to release these cells, and we can't do that. Again, in our ability to only minimally manipulate these cells, we can only kind of mechanically try and get these things to release, but cannot do them through enzymatic degradation before utilizing them. And so, again, some of the basic science type studies looking at these sources of stem cells are a little bit augmented compared to what we are using. And so we have to be aware of that too. And then again, paraconductivity is thought to be a very important role for these cells as well, just like the BMAC cells. Fat here is harvested through lipoaspiration or via operative tissue resection, either open or arthroscopically. Lipoaspiration harvesting techniques involve percutaneous infiltration of subcutaneous fat, often the abdomen or glute if there's not a lot in the abdomen, a high-level athlete or a skinny individual, for instance. You kind of flood it with local anesthetic and saline and then mechanically suction out, as a liposuction procedure, that fat. This tissue is then mechanically fractionated as stainless steel ball bearings, for example, can be used to break away some of the fat from these other types of cells, again, because we can't use enzymes to do this for us. Try and washing away these mature adipocytes before centrifuging in order to isolate that stromal vascular fraction, the SVF, from the majority of the adipocytes. And then seen here, you kind of see that breakdown of different layers of oil, the mature adipocytes, aqueous layer, and your stromal vascular fraction. The money is really at the bottom there. Similar to BMAC, there has been some early evidence in support of its use for Achilles tendinopathy, knee arthritis with or without concurrent surgical debridement, and as an adjuvant in focal chondral defect repairs, as well as lateral epicondylitis, and then good studies showing some benefit in chondral injuries at the time of hip arthroscopy by injecting thereafter, and microfracture plus type procedures as well, so cartilage reparative type procedures. And then Dr. Moorman, one of my future colleagues through Atrium, is utilizing this technology along with a comprehensive debridement and capsular release of early to moderate arthritic shoulder osteoarthritis conditions, and he's finding good outcomes there anecdotally and soon to be published. And there's a lot of our colleagues out overseas who are using it, particularly in Italy, for similar reasons, and finding, again, in shoulder arthritis, kind of early to moderate arthritis, that it has benefit. There's additionally several NIH-registered clinical trials underway, so we'll see down the pike a little bit more data out there in high-level study. Wren and Elliott all demonstrated in their study supraspinatus tendon cells treated with adipose-derived product had increased VEGF and cell proliferation potential, again, suggesting from a basic science standpoint that what we're hoping this is doing is increasing biology and increasing some of the growth factors and angiogenesis in these tissues, which inherently, you'll notice the theme being inherently that these are poor vascularity type situations, patellar tendonitis, rotator cuff tear, lateral epicondylitis, areas where they could benefit from new from new blood vessel growth. And then this small 12-patient cohort by Lee et al. In their 2015 study found significant improvement in pain and function and improved structural integrity on ultrasound a year after adipose-derived cells were used to treat lateral epicondylitis. And then finally, in prospective randomized trial comparing microfracture alone to microfracture with these adipose-derived mesenchymal signaling cells in 80 patients with large femoral chondral defects, Coe et al. Found in 2016 significant improvement in pain scores and cartilage coverage compared with the control cohort. Cartilage coverage on imaging is probably more of a fibrocartilage type fill like we see in microfracture, but nonetheless, the outcomes seem to be successful. I'll touch just briefly on amniotic membrane products and umbilical cord products to follow just for completion's sake, but with the full disclosure that, number one, I don't use these and haven't seen them used a lot yet, mostly because they're newer type therapies and we're learning more about them. And so it's something that I think as we continue to improve in our understanding will be more widely used because they're easier and they're allograft type tissues, so you don't have to go through the harvest effect as well autologously. But the studies out there from a publication standpoint are less abundant. And so amniotic membrane was first actually used as a biologic scaffold a century ago for the treatment of skin defects. And since then, it's gained popularity as such for biologic dressings and scaffolds for tissue regeneration because of its ability to reduce scar formation and its biologic barrier and antibacterial effects. And these don't contain live cells in their preparation after their freeze cycle from allograft harvest before use. But you'll see a lot of the data from this is going to come from not necessarily orthopedic type standpoints, but some of the ophthalmologic data is out there because they've been using it in the eye where, again, scar tissue is a huge concern and can't really tolerate any of that. And so some of the earliest data comes from their literature. Again, these graphs are full of anti-inflammatory factors such as IL-1 receptor antagonists and matrix metalloproteinase 1 through 4 tissue inhibitors. So again, you see some of the effects of not necessarily just the cells themselves inherently, but kind of how they're affecting that milieu inside of the area that you're injecting. These additionally have a high content of hyaluronic acid and small amounts of proteoglycans, and so some of that lubrication effect is probably inherent to its injection as well. Again, it's used in orthopedic surgery as infant thus far as evidence-based usage, but studies are beginning to evaluate whether it has efficacy in cartilage restoration, ligament or tendon healing, and plantar fasciitis or knee OA. We looked at this study just a few years ago and kind of systematically reviewed orthopedic literature of the topic of amniotic membranes to see applications in sports medicine. It seems to have promise as a source of pluripotent cells, highly organized collagen, antifibrotic, and anti-inflammatory cytokines and immunomodulators, as I had mentioned just a moment ago. But again, the current body of evidence in sports medicine and elsewhere is somewhat limited to more in vitro and animal studies with less so clinical studies in humans. And then finally, umbilical cord-derived tissue, somewhat similarly, is an allograft type of an option for us with a little bit less known clinically. But this is suggested to be the Wharton's jelly connective tissue matrix component of the umbilical cord that's most important. So it's extracted and processed and proposed as a source of MSCs cytokines, growth factors, and hyaluronic acid, and may provide some degree of scaffolding and structural integrity. Clinical evidence in human studies, again, is minimal at this time, but it's often being used in the clinic for similar things as we were using before, as far as injections for knee OA, cartilage type cases, and augmentation for those types of surgeries therein. And so just in summary, looking at the logistics of use of biologics in the clinic and the OR, cost of a single treatment can vary and does vary depending on whether this is being done in the operating room or in the clinic, and that's important to be aware of as well. And then concurrent needs for anesthesiology and imaging guidance. And so because most of these studies remain experimental by most insurance standards, it's difficult to get these covered. And so they can be expensive, and patients need to be, if they want these used, often have to be willing to pay out of pocket. And so, again, because of that, that's part of why I think we have that responsibility to let them know exactly what we think we're injecting, what the evidence is and is not, before they put some of their hard-worked money up front to pay for these options. Fortunately, these treatments are considered fairly safe, though. Really just pain at the donor site is kind of the main risk for these autologous treatment options. And in summary, though, there's a lot of potential with these biologic options, but there's a lot of things we haven't identified yet. There's solid preclinical, basic science evidence, but the clinical evidence you can see is somewhat lacking by comparison. So I think we still have yet to stumble upon specific variations of these treatment options and pathologies to treat and how to treat them and when. But when we make these matches, it will be significant. This is kind of the next step in how we're moving along orthopedic surgery and orthopedic non-operative treatment of our musculoskeletal conditions, because we've gotten really good at comparing time zero strength of different suture anchors for rotator cuff repair in the operating room and things like that. And so a lot of these mechanical things that we're improving on have made that side of musculoskeletal issues better. But that other side is biology, and those things need to get better too. Examination of these minimally manipulated and culture-expanded preparations have identified, again, inherent variability of these products as a major hurdle to proper characterization and evaluation as far as study. And so we need to try and standardize how we're describing and marketing these therapies. And from proprietor to proprietor, we need to understand from a research standpoint where those differences are, so that we're not doing what we did 20 years ago and suggesting some studies that said PRP was helpful for knee arthritis and some that weren't, and come to find years later, looking back at it, that it was because people were using leukocyte-rich PRP and knee OA and finding poor results, whereas those that were looking at leukocyte-poor PRP were actually the ones finding the success. So where do I see these values coming? I've kind of alluded to it, but from an injection standpoint, I think we're going to expand upon what we've seen initially based on the efficacy of early joint arthritis and overuse tendonitis pathologies. But I really think that a lot of this is going to come as an augment to some of the surgical strategies we're doing, again, to try and improve on the biology of things that we're mechanically tacking back down or fixing or putting back together. Thank you. So I'm not sure what the timing is. I'm happy to answer any questions, or if I should move on to the next talk, which is mine as well. So you all have to hear me a little bit longer.
What is your thought on 1 versus 3 PRP?
It's a good question. And some of that we see in some of the literature that's out there. I think 3 injections of PRP for something like knee arthritis has been shown to have derived benefit over 1 injection. And then the questions just come into individually as well as practitioners, whether or not that is worth the offset in costs from an actual financial standpoint, because those costs are either being tripled or some kind of bundle of payment for them. And so there is, I think, a basic science and clinical efficacy to that. And then just the question to patients is whether they'd be willing to and able to spend that amount of money to do it. But I think if all else equal, and cost not a factor, I think 3 injections has data out there to suggest that it's superior to 1 injection in the setting of things like knee arthritis or some of the other degenerative type conditions.